prescriber myself.
Lovely. Helen?
Hi everyone, lovely to see you this afternoon. My name's Helen Ireland, I'm the Pharmacy Workforce Lead for BNSSG. Thank you.
Thanks, Helen. And Lily today.
Hi, so I'm Lily, I'm the FCP Education Lead for BNSSG.
Okay, we've also got Roger on the call, who's just working away in the background, letting people into the meeting, etc. Do you want to say hi, Roger?
Yeah. Hi, I'm Roger Harrison, part of the Training Hub team supporting the event today. Thank you.
Yes, okay. And last but not least, my name's Mary Carter. I'm the Pharmacy Education Project Lead for the BNSSG Training Hub. So we have a welcome which we've introduced. If you could kind of introduce yourself in the chat, it would be good, rather than going around the screen, because we've got just half an hour for the forum today. So I think that'd be really good if you could just pop in the chat who you are. And then there's a few things that we're going to cover today. We're going to introduce you to the IP audit tool, which Lily's going to cover. Helen's going to do a little bit on a ICS update, independent prescribing in the foundation pharmacist training year specifically, and then hopefully we'll have some time for some discussion as well. Appreciate it's 1 o'clock, you're probably having your lunch. I hope it's as healthy as the bowl of salad that's on the screen there. If we're new year, new January, I know I'm doing dry January, which I'm already finding very challenging, but let's start this new year on a healthy note. Okay, so as I said, this is the second forum, and it was really good to see those of you who came to the first forum starting to understand what this forum is going to look like, and the idea that it exists for you as independent prescribers. And we did a little bit of a scoping exercise in the first meeting to kind of understand what you want from this forum and some of the themes in the image on the slide there. And like I said, this is about creating a community of practice for you, and some of the main themes that came out around what you wanted to use this time for was around sharing experience, around peer support, professional development, thinking about scope of practice. And in the follow-up email, which hopefully you all received, there were some questions that you can use to be thinking about reflecting on your prescribing practice. So that kind of feeds into that self-audit. So, you know, using this space to come together to have that safe space to share experience around your prescribing practice, but actually how you continue to use that those connections and reflections on your prescribing across those areas when we set those questions. So if you didn't receive that initial email, just pop in the chat. We can perhaps copy those reflection questions into the chat for you to go away and consider at the end of today's forum. So has anybody got any questions at this point before I hand over to Lily for the audit tool? Okay, that's okay. So I will stop sharing now and hand over to Lily, if that's okay.
Yeah, that was nice and quick. So let me have a little share. Roll this up. Make sure I get the right one. It's updating. Oh,
yeah, we can see it.
That is
no,
not.
That's
Don't know why it says that. That's weird. Okay, not sure. It's updated weirdly with quite a few ones that I've got on my desktop. I do apologise. So the plan was that we're from following doing that scoping survey we talked about in the last session. A key output was people were keen to do their annual auditing, but they didn't know how. So my aim was to design something that would help you as independent prescribers to be able to do your annual audit. Now, just so you're aware, this isn't a policy, this is not mandated, this is just as a guide to help you. I've put this in a presentation format, but the actual guide itself will be kind of in a Word/Excel document that you can use. We need to get it peer reviewed first before I disseminate it. So this is kind of very shorthand of what we'll be covering. So hopefully, I'm not sure if I did cover in the last one why it's important that we do audit or practice. It is part of the RPS standards, and we need to be very clear and about auditing or practice annually. And it is very clear with the CQC. So why are we auditing? Obviously, patient safety, improves treatment outcomes, promotes adherence to guidelines. We get very used to bad habits of doing stuff, and we sometimes don't, as clinicians, we often sometimes don't update or practice, and we don't realise that things have updated. So auditing or prescribing annually helps with that and promotes that. Cost is a big thing. Are we actually being cost effective? It allows for identifies training needs and reflective practice, and it's part of compliance. So hopefully all of you have seen the RPS guidelines. This is what the framework is, for a framework for all prescribers. So what are we doing when we're auditing? What are we wanting to look at? Okay, so when we're auditing or practice, we want to look at, is it the right drug or drugs? We're looking at, is it the right dose? Are we giving the right instructions, the right follow-up, documentation? Are we ensuring that there's a right review? Is it good prescribing practice? And then we need to look for any prescribing errors. So these kind of 7 key points here kind of cover the key points within the RPS framework. This is what we're hoping to look at. Okay. So I put in some details about what we would be looking at when you're doing the audit, when you're considering the right drug. I don't think we need to go through all this in detail. It's just there as a guide when you're looking at doing the audit. So there's some key points of what we're looking at. Are we thinking about right dose? Have we considered in our notes, looked at their age, weight, the renal, hepatic functions, etc. So a key thing here is making sure your notes are detailed and up to date. So it covers all the 7 points. So what are we doing? We're going to create an EMIS prescription search. Okay, I've created a guide on how to do that through EMIS. Some of you may already be able to do that. Some of your practices may be doing that for you. But if you don't know and your practice doesn't know how to, I've created a step-by-step picture guide on how to do it on EMIS, so you can produce your own search. And once you've got your search, it will give you everything that you've issued in the time frame that you requested that search. And normally it's a year. Then what you're going to do is you're going to select 10 random prescriptions to review. Now you can choose to do 10 random prescriptions, or if there's something very specific within your practice or you're aware of that you actually want to target, you can target those prescriptions. So it might be actually you want to look at reviewing your practice around pediatric prescribing. Antibiotic use is a big thing. Are we being appropriate for that? Opiate prescribing. So it can be 10 random ones, or you can do 10 targeted ones. It totally depends on you, because the whole point of this audit is not only is it about compliance for you being an independent prescriber, but you need to learn something from it. It's reflective practice. So it's not just a tick box exercise. You want to learn something from it. So if there's an area within your practice or within the practices, the GP practices, they want to look at about auditing and different prescribing, you can target it. Then the plan is that you're going to self-audit against those 7 points. So the right dose, right drug, is it good prescribing practice? You're going to audit using those points in that guide. Have you covered all those points? Then you're going to pass the same 10 prescriptions, because you've audited it, you've done it from your own view, your own viewpoint, and you think you've adhered to practice. You looked at guidelines, you looked back at your notes. With the same 10 prescriptions, you're going to hand over to either your clinical supervisor or an experienced independent prescriber. Normally, this is quite good peer review, so you could swap it between 2 independent prescribers to review each other's work, and they're going to review the same 10 prescriptions, covering those same points. And at the end, that experience, you're going to have an action plan. Were there any prescribing errors? Was there any learning points? So you can create a reflection. Does that reflection need to be done? And is there an action plan that needs to be completed? And that's essentially it. So I might not have done this in the best order. So how do we do that? So when you do, I don't know if anybody's managed to do an EMIS search. When you do an EMIS search for your prescription and you download it as an Excel spreadsheet, you get, it's probably not, I was trying to get, the problem is I was trying to get everything in, so it might not show up very well, but you should get a large spreadsheet that gives you, you know, your EMIS name, the full name, sorry, EMIS number, full name, you know, your age, date of birth, gender, date of when you issued the drug, if there's any linked problems to it. So that's what you should get. And you're going to select 10 from there. And with this Excel spreadsheet that I've produced, you're going to put it into this kind of format. So you're going to copy and paste over those patient details, which will get you up to the linked problems. And then you're going to go for it. Was it comment on right drug, right dose, right dose instructions, right follow-up, and you're going to comment through that. So that's what it will look like. And that's basically your audit. You're going to complete that, and then you're either supervisor or an experienced independent prescriber who's going to review that. So you're going to do a self audit, and then someone else is going to audit the same 10 prescriptions. And that technically would be your audit. So as an example, we've got here, you know, we're giving Pen-V for a 22-year-old. That was the dose instruction that came up, take 1 tablet 4 times a day. Was it the right quantity of dose of medication? So right quantity of tablets and the link problem. So then when we're looking at it, it should be very simple. This isn't a really detailed thing. And we're looking at through those seven points. Did we do the right drug? Was it the right dose? And we're just commenting. And then there's an area at the end about, was there prescribing area or was it suboptimal prescribing? Some could argue here that actually we should have given 10 days as per the policy. But you can argue there why you might have given 5 days over the 10 days. So you might want to comment in suboptimal prescribing. But that's essentially it. So you do 10 of these. Your supervisor or the experienced and independent prescriber will do the same prescriptions but review it in the same way. You can compare, and then you come up with an action plan. You reflect if there needs to be a reflection. You complete an action plan, and then you complete an annual declaration, which will be in this Excel spreadsheet, and you're done. That's you for your annual auditing. So apologies that this doesn't actually show you the actual document itself, just because it's an Excel spreadsheet and it's very wordy, and I can't put that all on a presentation. But essentially, it's very simple that I've put together a guide on how to generate the search on EMIS, so you can actually get those prescriptions. You're going to self-audit 10 prescriptions, same 10 prescriptions. You're going to get someone else to peer review them using that template. And then you're going to see if there's any action plan from that. And then a part of that, there's going to be a self-declaration for the end of the year. So covering all the key points as part of the RPS framework as a self-declaration that, yes, you've audited and you feel you're fit to practice to continue as an independent prescriber. And that should really cover it. We don't need to be super, super detailed, but the whole point is it's supposed to be a learning and reflective practice for you as well. So that's why I say be random, or you can choose to do what you want. And that's it, really. So as a whistle-stop tour through that. Any questions? Is that simple? Is that as easy? Do you feel that as easy as can be? Go on, Sally.
Yeah, really easy. I think that's what we do. I've done anyway, because we've got our own local one, which Penny will know. But that's what we've been doing for the past year or so.
Yeah.
And that's what I've done. Are you going to I didn't think about the EMIS search, but are you going to send out details of how to do that? That'll come out as a pack, will it? So
yeah, absolutely. So I can show you. Let me pull up again. I need some more people to peer review this to make sure it works. So it worked for me. I'll show you.
So if anyone's happy to be a peer reviewer, please do let Lily know, because that's really helpful. Because if you're in practice and you can do it, that's really helpful.
Hopefully this one. I've got so many drafts up on my screen, you see, so I'm just making sure this is the right one. There you go. So literally, it looks like this. I put together a guide and it will show you
Oh,
step
brilliant.
by step on how to do this yourself. It's not actually too hard. And once it's done, and it's there forever on EMIS under you. So you can just go into your folder and you can just press run and it will run every year you want to do it. Or if you need to do it twice a year, it will just, once it's set up and it's there. Obviously, if you need move practice, you need to set it up again. But that's what I've done. It's as simple as this. I've tried to make it really easy. So not only will it show you how to get those prescriptions rather than manually going back through your diary and figuring out where you've prescribed, it will just do that. And like I said, you can just randomly select, or you go, actually, there's a big thing around antibiotic prescribing. We want to look at, am I actually adhering to guidelines? I'm going to pick 10 prescriptions where I prescribed antibiotics and then review it in that way. Does that make sense, Sally?
Yeah, no, that's brilliant. I mean, I'm happy to, because my appraisal will be coming up in a few months. I'm happy to
Perfect.
Run it for you if you like.
Yeah, just I'd rather before then disseminate out to everyone just to see if there's anything extra we should be adding in there. This is from my viewpoint. I need everybody else's viewpoint. If there's anything extra or you think it's too much, because what I don't want is that some of the stuff that is out there, there's loads of stuff out there. It's really detailed and a lot of work. A lot of them ask for 50 prescriptions. You know, we don't have time, and actually sometimes quantity is not quality. Go on, Mary.
Yeah, I was just going to check with the idea of doing 10.
Yeah.
Is there an evidence base behind that? Is it because I'm just kind of thinking, if you're a very, very active prescriber and you do a lot of prescribing versus if you're somebody who has a less active role as a prescriber, 10 could be a higher proportion of somebody's practice than somebody else's. So it's a challenge when we pick numbers out of air for competency based assessment of people's ability, but sometimes they are arbitrary, and
I mean, it's true. I did see something, and the Royal College GP uses they suggest getting 50 prescriptions, then auditing a small amount of those prescriptions. I've seen other audits where it's 3 prescriptions, some are 5. There's no real number, and that's the difficulty is, and I totally get it, when you're run an audit and I've done 1,000 prescriptions in the last year, you might not get a really big picture, but it's hard, isn't it? If you're spending, you could do 50, but that's quite a lot of time to do that. So
and I guess my second point is that sometimes prescribing is about the decisions you make not to prescribe as much as they are about when you do prescribe. So, how is it about auditing consultations rather than actual prescriptions? I know that, where it's actually making prescribing decisions can be sometimes about de-prescribing rather than actually issuing an actual prescription, but I know that's probably a wider kind of
that's really wide, and I suppose that just covers your clinical practice. And I suppose we're looking at people who are safely prescribing. You're not gonna, I get your point, you could actually cause harm by not prescribing someone something, but at the same time it's about, the whole point is you're auditing, are you prescribing safely? Because obviously the dangers are you can really harm someone if you've got poor prescribing practice. Yes, that would be great, but I
suppose there's an element
it's like
where
auditing your practice then and not your prescribing, because then it's really detailed. Go on, Kerry.
Could you not use that template to add a few examples of maybe cases where you've not prescribed? I wonder if it works for that at all.
The problem is that the audit wouldn't pick up anything that you haven't prescribed, so you'd have to trawl back through. So the only way you can add into that is that you produce one reflection on an area, or 1 or 2 reflections on an area where you chose not to prescribe, and you'd have to manually search. Isn't it? Yeah, you'd have to manually search for that, because the whole point is that it won't show when you haven't. Otherwise, you could produce an email search on how many consultations you've done, and I've audited. I've audited consultations like that when I've had to find stuff where I've kind of chosen to issue something, but I couldn't prescribe at the time. and it's a lot of work to go back through notes, thousands and thousands of notes. So I do get your point, but yeah, I don't know what people's thought is, whether actually there should be a little reflection there at a time when you chose not to prescribe. Go on, Carly.
I think that looks brilliant, Lily, and I would definitely give that a go. With the peer support thing, sorry, I missed it because someone was asking about turning my internet off, and I was like, no, don't. Did you say that, say I could do my spreadsheet and then hand it to someone else to review it, but I couldn't do that outside the practice, could I? Because they'd need access to my patient's EMIS, is that right?
Yeah, you need to be within your practice. That's a good point I'll make there. It should be within your practice because they need to have access to the EMIS notes. And I suppose ideally I'd probably want to do a bit of a webinar to do some examples around why it's important you audit and how that links into your consultations, and why your consultations are really important to be detailed. But it has to be within your practice. I would suggest, when I say an experienced prescriber, I'd probably go off the same point that it'd be a DPP, so 3 years. So a GP or someone who's 3 years post getting their qualification probably makes sense. Now, certainly when I used to do these audits, I used to just swap them with the nurse or my nurse practitioner, and we just swap them over and get them to review each other's work.
Cool. Yeah, I've got a few people in mind. No, that's really helpful. Thank you very much.
Perfect.
We'll just take the last question from Noelle, and then we'll move on to Helen for the last agenda item, if that's okay. Hi, Noelle. Oh, you're on mute.
So it was just to say that the GP trainees already do this prior to them qualifying, so they do a similar thing. I was just wondering how you would write up if you'd done a repeat prescription. So you've not actually documented the first sort of, like you've done a med review, somebody asks while you're there, could I have a prescription for my amlodipine, I'm running out. So it's quite hard to show that you've got the good documentation and everything, because you're not going to really be counselling them on every single prescription because they've had it for ages. So how do you write those ones up, Lily?
That's a good point. And I suppose what would be in there is it's different when you're just, the difficulty is when you're just instantly doing an EPS prescription, aren't you? Where it just automatically you're going through like the hundreds that's there, and you're just automatically pressing the repeat button. It might be one that actually you don't audit, or is it someone that's come in and said, I want to repeat on my amlodipine? Should there be somewhere within your notes to say double check that the patient has had those initial bloods done and the follow-up and repeated their blood pressures, say, whether that needs to be in there in the consultation? Certainly it's a bit different when you've just doing repeats and you're just pressing that button, if everybody knows what I mean, when it's just like, right, they're re-requesting. Yeah, you probably have to be a bit selective when if you've randomly selected that prescription, it comes up and it was just literally a repeat, whether that's not one you're auditing.
Yeah, so maybe just focus on the ones that you've started rather than
But then there is a lot to be said, the ones that they're on a repeat but you've had a consultation with them about whether to continue. I think that's important as well. It's just, I think until you start doing it, I don't know how it's going to show when you're I don't think it will show up on the EMIS search if you've just said yes because you're not the initial prescriber. I don't know.
I think there's lots of technicalities that we can start to think about. What's the next steps, Lily? And then I just need to move on to Helen.
So next steps is this will put this actually in a formal document. I will share it with some people to peer review, and then once that's done, hopefully we'll get this done by the end of the month. Anyway, I don't want it dragging on, and then we'll disseminate it, and then it'll be a case of if you want to use it, you can use it.
Yeah, I think we'll definitely use this space to start the conversation around it, and people who are using it, what's their experience and feedback as it sort of shapes the tool moving forward. So thank you, Lily. You'll share the slides with everybody for after follow-up. Yeah, okay,
absolutely. But it will be in that document anyway. I was just trying to shorten it for you.
Fabulous, thank you. Thanks, Lily. It's great work. I think it's going to be really helpful, a really helpful tool. I'm going to move on to Helen. Sorry, Helen, we've got a little bit of time for you to cover your couple of slides on what's happening in the pharmacist independent prescribing space and the foundation training year. Thank you.
No worries, thank you. Thanks, Lily. Excellent self-audit tool. I can see that being really helpful. So yeah, just here from a BNSSG perspective, I just wanted to firstly, or two messages, two slides. The first one is a thank you to any pharmacists that took part in our independent prescriber questionnaire that went across all sectors. We had 52 pharmacists from community practice and 54 from general practice respond as part of our nearly 200 responses. So if there's any pharmacists in the space that have replied, that's thank you. And part of that was to identify those who are not IPs, but also those that are IPs and maybe DPPs of the future. So I will be in touch with people who have replied to the questionnaire to support in that sort of extension of the DPP status. And if you haven't replied but would like to know more about becoming a DPP, then please do get in touch with me, and I'll put my email in the chat in a second. The other thing I just wanted to flag, trainee pharmacists. So just to bring this to your agenda, whether you're a pharmacist or not, or pharmacy background or not, but to train as a pharmacist, you have an MPharm for 4 years at university, then you graduate and then have a year in practice, which is now called the foundation training year. And just to make it clear to everybody, from this summer, all the trainees across the whole of the country will have prescribing as part of their training year. So we have 40 trainees in BNSSG. So it may be that in your practice or your community pharmacy, you may have contact with a trainee pharmacist. So whether that's as a nurse, as a pharmacist, but whatever, but it's having that understanding that they are having prescribing as part of their final year of training. And sort of part of that as well, if you are thinking you might want to have a trainee pharmacist in your setting going forward, and particularly talking to the pharmacists in this space, please get in touch with me. So this is for our 26-27 cohort, which I know seems a long way away, but believe it or not, the planning is in process and we need to confirm that by the 1st of March. Then do get in touch for further help from me if you need it. I will send these slides to Mary. Oh, thank you. Put my email address in the chat. Thank you, Mary. But please do get in touch if you've got any questions about, let's say, the DPP status, and also about pharmacists in training in either general practice or community pharmacy. Thank you, Mary. I'll hand back to you.
Thanks, Helen. Just to say, myself and Helen have been running a couple of webinars for people who are interested in general practice for employing a foundation year trainee pharmacist. I can't remember the date of the next one, but I'll share that on the Teams. And then we're also running an Oriel masterclass for those people looking to add those places onto Oriel, because it is quite complicated. Thank you so much. We are at 1:30, so thank you so much for your time. I hope you probably enjoyed your lunch whilst you've been at the meeting. The next, we'll put the dates to book for the next forums on the pharmacy Teams channel, and probably in the follow-up email as well, and we'll send you some of the resources from today. The reflection questions I've popped in the chat, there's some contact details in the chat, so please do revisit the chat after today, and we'll be in touch shortly after the event. Please do fill in the feedback form. The link is on the chat as well, and will be in the follow-up email. But thank you so much again for your time joining us this lunchtime, and we hope to see you all again soon.
Thanks, everyone. Thank you, Lily. Thanks, Mary.